Good afternoon. Let's reconvene our afternoon session. Before the case discussion, I've been asked to answer the question this morning about the number needed to treat for patients on osteoanabolic therapy. Let me explain why that was a very difficult question or impossible question for Dr. Belazikian or for any of us to answer. Remember that the number needed to treat is an index of efficacy. It is the reciprocal of the absolute risk reduction. The absolute risk reduction is the risk or of whatever event we're looking at. In osteoporosis is fractures in the control group minus the incidence in the treated group. And then the number needed to treat is the reciprocal, 1 over the absolute risk reduction. So as an example, in the vertebral fracture arm of the FIT trial, where women at high risk of fracture were enrolled, they were followed for 2.9 years on placebo or alendronate. The fracture incidence or rate in the placebo group was 15%, was 8% in the treated group, with an absolute risk reduction of 7%. 1 divided by 7% is a number needed to treat of 14. But you have to qualify that because the patients were treated for 2.9 years. So if you want to know the number needed to treat for 1 year, you have to then factor in the interval of therapy. In that same study, you could calculate the number needed to treat for whatever fracture you wanted to look at, and you get really different numbers. So asking me what the number needed to treat of alendronate is not a very specific question. I need to know what kind of fractures you want me to tell you the number needed to treat for and how long the patients are treated. So you can look at the table and choose the number needed to treat you like the best if you want to ask me that question. It also is totally dependent upon the risk of the population. In the clinical fracture arm of FIT, patients at much lower risk were enrolled. They were treated for 4 years, and the frequency of fracture in the control group and the alendronate group were much lower, and the number needed to treat was 78. So if you ask me what's the number needed to treat for alendronate, it could be 14 or it could be 78. That without asking me more detail about that. The interval again is in the same study can be demonstrated. Here are data from the Freedom trial. You can have the vertebral fracture risk reduction at 1 year and 3 years. At 1 year, the number needed to treat is 78, and at 3 years is 20. So again, ask me the number needed to treat over what interval of time is important. So one can calculate the number needed to treat for the various anabolic drugs for different studies. With teriparatide, we've got the pivotal fracture trial that enrolled very high-risk patients, and the number needed to treat was 11 in patients who were treated for an average of 21 months. Or if you normalize that for a year, the number needed to treat would be 18. In the active trial, there was a placebo group, an abaloparatide group, and a teriparatide group, and the numbers needed to treat over 18 months were 28 for teriparatide and 20 for abaloparatide and 29 for teriparatide. For romosozumab, of course, we have 2 studies, a placebo-controlled trial where we can look at the number needed to treat over 1 year and was 78 in a very low-risk population, where the risk of fracture in the placebo group was only 1.8%. If you look at 2 years, while everybody was receiving denosumab the second year, the number needed to treat is lower. And in the ARCH study, now we have no placebo, but an active comparator. So you can calculate the number needed to treat of romosozumab compared to alendronate at 1 and 2 years. So you can get a whole variety of numbers that you can look at. So I can make the table for you, but it's meaningless unless you do all the right things. So in order to make comparisons or use NNT to compare, you have to have treatment groups that are identical in risk of whatever outcome you're measured. They have to be treated for the same duration of therapy. And in the case of osteoporosis, you have to ask which fracture type you want the number for. So that's the answer to the NNT question.
Pretty hot out.
Hi, so Micol and I are going to co-moderate this. Micol is going to take the questions from the computer. Our first presentation is from Leela Khan, who comes from the Cleveland Clinic. And the format for this is a 5-minute presentation and 15-minute discussions. And we have a lot of people up here to discuss because of the situation. So Leela.
There's Band-Aids in my wallet, and I'll promote you small, honestly. Everybody whispers out when you're ready.
Good afternoon. Thanks so much, first of all, to the organizers of this great symposium to allow me to present this case today. I wanted to discuss a case of tumoral calcinosis that I saw in the clinic, I think probably a month ago. So no disclosures. There's not too much stuff to this case because unfortunately, even though my practice is almost exclusively bone and almost exclusively in person, this patient lives quite a distance from Cleveland. She comes from Michigan, and so it was actually a virtual visit. So the case is a 67-year-old female. She has type 2 diabetes, very well controlled, osteoporosis. Unfortunately, I did not have the bone density report at the time of my visit or even now, but she presented to the office. She saw the neurosurgeon that I work with, Dr. Krishnani, with a painful mass in her spine several months before. And her pre-op labs surprisingly looked great. So there's really not much to this, as her phosphorus was fine, her PTH was fine. I know this is a small slide. Her vitamin D was slightly low. And basically everything looked quite unremarkable. So Dr. Krishnani, who I work with, because of exquisite pain in her spine and a very large mass in her spine, removed the tumor. And this is a picture of the tumor that was there. It was, I called the radiologist to discuss the imaging characteristics, and they said it was 100% tumoral calcinosis based on these kind of amorphous, irregular appearing calcium deposits that are hypodense. And the mass was quite large, 7.5 by 6 by 4 centimeter mass. These calcified material was surrounded by dense fibrosis. I also spoke to the pathologist who confirmed that this was indeed, in fact, tumoral calcinosis. And the main question that I posed to the group and the panel today is what to do next, because the patient was reporting new lesions in her spine, and she was quite concerned to see if there's any additional treatment that could be done to prevent them. I did review the imaging of the spine with the radiologist before coming here, and the individual I spoke with did not see any other lesions, but the patient feels very adamant that she's developing new masses in her back, which are causing exquisite pain. And so the clinical question was for the group is if there's any treatment available for someone who has primary tumoral calcinosis, which is, in her case, not associated with renal failure, any role to give bisphosphonate.
Any thoughts, Michael? Yeah.
Oh, that one. Okay. Well, so she's normophosphatemic, right?
Yes.
So as you said, this would be a case of normophosphatemic tumoral calcinosis, if indeed it is tumoral calcinosis. I'm not convinced it is yet. There is a specific gene mutation that's associated with that. It's SAMD9. That could be something to check. So those MRI imaging is the only thing she had, right?
Oh, she had MRI and the tumor was removed.
What's that?
The tumor was removed, so I confirmed.
Yeah, no, but my point is that MRI is terrible for looking at calcified lesions. A CT actually would have been much more helpful.
Oh, okay.
And in fact, if she has tumoral calcinosis of familial or not familiar, again, well, an imaging study you could do is a bone scan, a fluoride bone scan, a sodium fluoride PET CT scan, which would give you detailed information. Sodium fluoride PET CT is not widely familiar to a lot of people. Sodium fluoride was actually the first PET agent ever approved. It was approved before FDG PET. It's cheap. It's $100 a dose. Anybody who's got a PET CT scan, the nuclear medicine department can order it. It's a great imaging study for looking calcification anywhere in the body, so you could definitively say whether she has multiple areas of calcification taking place. It's extremely sensitive. I don't know of specific pathologic criteria for what determines something is a tumoral calcinosis lesion. Your pathologist has an impressively high degree of certainty on that. So you could ask for a second opinion of that as well. But if she has this non-familial tumoral calcinosis, if she has calcinosis of any type, as I said, the treatments for it are terrible. They're not very good. They're not very effective. And even less so in somebody who doesn't have dysregulated phosphate homeostasis. So I can help with the diagnosis, but not the treatment. I'm sorry. But I do think that more imaging could help you get a better sense of exactly what she has and the extent to which she has it.
Thank you. And I should add, she is adopted, so the whole family history is limited, although she does have 2 healthy children.
I mean, these are tough things to do. The one thing you don't want to do is go in there and spill everything all over. And I think that's one of the issues, is that you do an incomplete job and then everything gets spilled, and then it's just everywhere. Number 2, I think that these things occur often in sites of trauma or injury. Sometimes you'll see people have wear a band and they'll carry something and they'll get it where they're loading their tissues. So to try to avoid that particular area. But, you made the point that she's diabetic. Diabetic tissue is not healthy. So that's one thing I would really work very hard at, is to get her under absolutely perfect diabetic control. Because I think this gets started in areas of injury or of bad tissue health. If you try to use chelators or anything like that, or using Diamok, things like where they try to take it out that way, does it work at all?
Yeah, no, we've tried chelating agents and they've not been very effective. We've tried topical.
Yeah.
We do have a colleague who, the other thought I had based on something that Joe said, you can get areas of calcinosis associated with a list of inflammatory conditions. It's usually pretty like dermatomyositis, conditions like that. They can get calcification, even ossification. And my guess is that, she would have had some symptoms of inflammation. You could always check a CRP or something like that. But no, we haven't found the chelating agents to be very effective.
Going back to.
Excuse me, we're having a lot of trouble hearing in the back. I think maybe if we could move the microphones closer up front. Thank you very much.
Sorry about that. You need anything repeated? So, okay.
So I'd just like to comment, I echo Mike's feeling about questioning the pathology. There have been cases where I've received pathologic diagnosis of things that were with 100% certainty, but it seems like they got the whole specimen, but I might inquire more about the actual diagnosis and potentially get a second opinion from a pathology reading.
Oh, get a second. Yeah, because I did call the pathologist and I called the radiologist, and they, yes, swore up and down it was, but.
I just get worried when someone's 100% certain of anything. That's all.
In the old days, this is going way back, we used to try to treat soft tissue calcification with IV etidronate. Remember Didronil? The oral, you don't get enough bisphosphonate in the circulation with the oral. The IV etidronate had data with regard to inhibition of soft tissue calcification, because the ratio of inhibition of mineralization to resorption, the etidronate was 1-to-1, in contrast to the amino bisphosphonates where it's 1,000 to 1.
Yeah, so we've examined some of these calcinosis specimens, and they are pyrophosphate. They're collections of pyrophosphate. So etidronate could be the only bisphosphonate that could potentially inhibit the growth of the pyrophosphate crystal. So it's an idea.
Yeah, the problem was,
I don't think you can get it.
you can't get it again. It's the problem is you
Although there
can't,
is a study with Tidronate in Holland. I don't know where
you
they're
you can
getting
get it in
from.
Europe. You
Yeah.
can't get it here, yeah.
Layla Tabatabai, I'm with the Houston Methodist Bone Health Initiative, and Steve Petak just reminded me. I've actually over at Methodist, we have treated a case of calcinosis cutis. So not quite the same thing, but it did present with calcified lesions all over the lower extremities and upper extremities of a patient with, in fact, dermatomyositis is one of the, as Dr. Hollins mentioned. So we actually treated that patient. Well, I can't actually take any credit. She treated herself by getting tattooed. So she's an avid bodybuilder with very lean body mass. So these, calcified lesions were extremely prominent, and actually visible, and she would cut herself shaving, and it was, just very, very distressing to her. In terms of how large they were, and they kept growing. And her juvenile dermatomyositis was completely in remission. She had no issues from that perspective. Urine calcium and all the other laboratory was normal. And she actually had a very large tattoo on her thigh and noted that a very painful lesion underneath that had completely dissipated. And then she actually underwent dry needling. So it was basically tattooing without pigment deposition. And her tattoo artist kindly agreed to do this for her. And we measured it with volumetric CT. We quantified the calcium in her lower extremities, and there was about an 84% reduction in the volume of those calcifications after the microneedling. And so the idea is that potentially there's recruitment of anti-inflammatory cells, or some sort of pathways being triggered by this. And so we're thinking about partnering with dermatology and rheumatology, who see a lot more of these cases probably. We published on it, actually. It's a case report I published with Deb Selmeyer and one of her fellows. I believe it's an OI, if I'm not mistaken, but we have a lot more detail in that publication about it. So not sure it would be of application here, but it's maybe worth a try, right? Derm can actually do the microneedling and at different depths. So
Good state
know.
of mind.
Thank
So
you.
it looks different during the day. It's very colorful, is what we're calling it.
Please mute your microphones online if you're not.
What did you
asking a
guys
question.
do?
Mia
The what?
Verma from Atlanta, Georgia.
Oh,
A
they
thought
have a
that crossed
beach
my
house
mind
too?
with heterotopic ossification,
Oh,
particularly
I'm pretty
with
sure there's nothing liberal
quadricep
about
trauma
what
and the
they
use of
own.
indomethacin
Their
and the role of an
condo is
anti-inflammatory,
incredible, isn't
particularly
it?
in that that could regress the potential formation of
Yeah.
that. Not sure if this would be of any help.
Thank you.
Any other comments? Oh, good. All right. Thanks so much.
Thank you.
20 minutes. Right on time. The next case is by Ann McKay. Ann comes from Grand Rapids, Michigan, and to talk about a case with secondary osteoporosis. Ann?
Do I need to advance these or will they do that? I guess I do. So, yeah, thank you to the organizers for allowing me to present this case. I'm a nurse practitioner in an orthopedic practice, but prior to this, I had 10 years of experience in hospital-based osteoporosis programs, and just recently came to ortho to develop an osteoporosis bone optimization program for them. So my patient is RJ. She's a 70-year-old Caucasian female. She sustained a intertrochanteric fracture in January that was nailed successfully. She has a prior history of an L2 fracture. That was a acute fracture that occurred. She had some pain. They did the imaging. There was some bone edema, so they knew it was acute. There was no fall or trauma that caused that. She's naive to osteoporosis therapy. You'll see in a minute, she has a very complex medical history. I always like to say a little bit of the gestalt of the patient. This is a very smart, well-educated patient. doctorally prepared psychologist, and really very good advocate for her health. When you see her history, you'll know that she's been advocating for her health, or I don't think she would still be alive and well. She's followed by cardiology. She has AFib, endocrinology, rheumatology, nephrology, and gerontology. So she's a nightmare in terms of care coordination because these are from 3 different healthcare systems in 2 different cities. And that plays into my management of this patient. So I do think one thing that was striking about this, she's a very good historian, and she makes a good case for the fact that with all these specialties, bone health was never brought up to her. So I don't know who leads the charge in this when you have so many specialties involved, each of whom have a little piece of bone health input and have a responsibility for secondary cause. So she has a number of etiologies for secondary osteoporosis. She's had AS for about 3 decades. Interestingly enough, she's not being treated for it. She's not on a DMARD, she's not on a JAK inhibitor. It's really just not being treated, but she's had extensive spinal surgery for it. She's stage 5 CKD on venous dialysis. She has Forster's syndrome, which I had no idea what that was, been looking up. It's DISH. She's type 2 diabetes, which is currently well controlled, and she has some nutritional issues, even though she has a normal BMI because of her gastroparesis. So she was referred to me by the orthopedic surgeons. I opened this chart and I immediately said, we need to send you to an academic bone center. For me, that would be U of M, because this patient is really kind of out of my scope of practice. However, she refused. So I said, well, I can take her to the echo. And then I was very nicely allowed to present that here. So I'm looking for input. She's an extensive med list. Her risk medications are her Coumadin for AFib. She's on a chronic PPI, and she does have some history of a steroid use. These are the supplements that she came in with. I'm not sure who prescribed them, but she's on the cholecalciferol high dose weekly, calcium, magnesium, and phosphorus. She does have some renal anemia. Here are her DEXA results. I will say the other thing about this patient is she got her first DEXA at age 67 by her primary care provider, but there was no intervention at that time. This DEXA was ordered by a primary care provider after a fracture, but at the point that I saw her in July, there had been no communication and no intervention. So that's something that I see a lot in general bone health practice. So spinal bone density couldn't be assessed because of her hardware. She had essentially normal bone density in her non-operative right hip, osteopenia in that 1/3 radius. We made a comparison to her initial bone density from 3 years previous, same bone density scanner, equal comparison, 3 to 4% annual bone loss in the hip and the radius. She didn't have any occult vertebral compression fractures. We knew about L2, elevated FRAX scores based on her history, parental hip fracture history, and her GCS exposure. And whenever I see numbers like that and looking at the patient clinically and then looking at those numbers, I think, who did this DEXA and who read this DEXA? But this is a healthcare system in West Michigan that has ISCD certified techs. The person who read it was ISCD certified. And although I let my CCD lapse a couple of years ago, I overread all my DEXAs. So this was good positioning and legitimate numbers, as best I could see. These are her lab results. Obviously, her renal disease is very prominent with her hyperparathyroidism, the phosphorus. She came in with a D25OH that was normal, but I did D125. Serum calcium's normal, LFTs, alk phos were normal, magnesium. Because of the fracture that she had with no trauma or fall, I did do her SPEP and her UPEP. They were both negative. Her capital light chain, I did. They're all elevated. A few months ago, there was a really good echo conversation about capital light chain. And I honestly don't know why they're elevated or what to do about it. In our in our community, I refer to oncology, but they gave me some guidelines. Oncology does not want to see these patients in my community if they have a negative UPEP, SPEP, and their kappa lambda ratio is less than 2. But I still worry about this because I drew this, I ordered the slab and I'm not sure what to do about it or what it means. Her bone markers were elevated. CTX kind of at the top of the range and a very elevated P1NP, which is one of my questions. I'm not really sure,
She's on
what
dialysis.
the underlying pathology or the underlying cause for that is. So I have a zillion clinical questions about this patient, but I did tell her she refused to get any other treatments. So I think my main question here would be, how do I treat this patient? And then kind of a sub question for that is, do you treat a 70-year-old patient with this number of comorbidities, in terms of her lifespan expectancy? So.
Thank you. Anybody from the panel? Emily?
Yeah, I think those are, I mean, it sounds like a very challenging case. I think, a few thoughts that I have. So, your CTX and your P1NP are renally cleared. So those will be elevated if
And
you
I feel
have
bad for
patients who
this
have
PA
CKD
who's
and
presenting
especially end-stage
because-
renal disease. And so we
Anyways,
sometimes like to
I'll talk
check
to you when you.
a bone alk phos in those cases, which may be a little bit more helpful in terms of telling you about the bone turnover, which is an important question when we're thinking about the bone disease. In these patients, we're thinking about bone turnover, we're thinking about mineralization, and then we're also thinking about, the microarchitecture and the amount of bone. So it's complex and multifactorial, but I think that might be a helpful lab for you in addition to the PTH in terms of thinking about what her bone turnover is. And you're right to wonder about a low turnover state in this patient, which would certainly make you try to stay away from certain treatments. And she is diabetic, which we think can also be associated with lower bone formation. So I would certainly think about that. And I know you mentioned she had a history of glucocorticoids as well. So I think those are all important things to take into account. And I'll let other people chime in, but also in terms of the spine bone density, yes, you have hardware there, you can't measure it, but it wouldn't be helpful in a patient like this either. We think their spines are usually artifactually elevated. They can have calcification of the aorta that's overlying it, making it look higher. The 1/3 radius is sometimes actually the best site with DEXA to get an understanding of their underlying bone. But I certainly think that the history of fractures is, that's impressive. And I would certainly consider it to be somebody who's at very high risk for having further fractures. And although it's not going to be simple, I would think about treating somebody like this because she, if she's can have another hip fracture and have, and have a huge impact in her independence and potentially mortality. So I would.
Thank you. A quick question on that. If their alk phos is normal, would you still go do the isoenzymes looking for the bone?
Yes,
Yeah,
I
okay.
would. And you want to take into account what what the relative value of those labs are. So her PTH is a little bit elevated, but it's actually not very elevated for someone with stage 5 CKD. And, I think the guidelines now say between 2 and 9 times the upper limit of normal. So she's actually a little bit low with that. So again, I think you're right to be wondering if she has low bone turnover.
Thank you.
I have a question. That I'd love, Paul, for you to answer, which is regarding the treatment. But I have a question for the presenter regarding her case in terms of her fracture that she had last January and how she's recovered from that. Because I think that would inform kind of my treatment decisions where she is. She clearly was at risk before because she had the old L2 fracture, and you're right that it wasn't detected before. And it's not uncommon that DEXA does not predict who's going to fracture. And with regards to dish, that definitely will mess up any spinal bone quality image because it's really calcium that's bridging between the vertebral bodies, and you have to have at least 4 contiguous ones for that to occur. And it's kind of interesting that she has ankylosing spondylitis and yeah,
That's exactly
Yeah.
what our physiatrist said. So
I mean, so that was my other comment, that I think it's really interesting that you say she's very educated and she wants to be a proponent for her health, and she has all these healthcare practitioners, plus not just at one institution, but at 3 different ones. And then you kind of said, this is beyond me, and she was still very adamant about staying with you. So all of those things are making me think about what to recommend to this patient, but I will defer to Paul.
yeah, your point about the AS and the dish, was I brought that to our physiologist because I thought that was unusual too. And
Yeah.
we're still looking for x-rays. She fell in her home, fragility fracture. And so the fracture was nailed, and surprisingly, this hardware is still in place and it's healing well at 4 months. So 5 months. Yeah.
Well, as the only card carrying nephrologist, I think here on the panel, a couple of points. You can't use WHO criteria or fractures to diagnose osteoporosis in this population with stage 5D CKD, because all the bone diseases that accompany CKD to this degree, whether that be hyperparathyroid bone disease or adynamic bone disease, can have low T-scores and fracture. And so, I mean, the gold standard obviously is double tetracycline labeled quantitative bone histomorphometry, bone biopsy, but that's not available very widely. The issue is the fact that in this population, this is where the alk-phos and the PTH can be very helpful. In this case, if the PTH is below 150 and the alk-phos is in the lower quartile of the premenopausal range, on biopsy, there's about a 90% positive predictive value for adynamic bone disease, which is what I suspect that this lady's going to have. And then in that case, even though with a mild elevation of PTH for the fracturing patient, I would treat it with teriparatide or abaloparatide. In 2021, we published the first case in the world, as far as I know, of a paired bone biopsy before and after in the American Journal of Kidney Disease in a patient with biopsy proven hip fracture and a adynamic bone disease. Showed the reversal of adynamic bone disease with teriparatide in that case. So it's worth a try in a high risk patient.
Can I say one thing to ask Paul? I thought that's what you're going to say, but with her kappa chains being positive and wondering about what Matthew Drake says, that the last I communicated with him, he would recommend abaloparatide over teriparatide with that concern. So I wondered if you had any comments on that.
I'm sorry, I missed the question, Deb.
So because of the possible MGUS history, there was question about stimulating the bone marrow and causing any malignancy. But I think that Matthew Drake, who studies this, last I spoke to him, that if he were going to use something, he would actually choose abaloparatide over teriparatide for that reason.
Yeah, we use both of them in patients that are fracturing with MGUS or myeloma without changing the bone marrow microenvironment. The University of Arkansas myeloma transplant program routinely uses teriparatide in their myeloma cases that are fracturing without altering the bone marrow. Last year at the Santa Fe Bone Symposium, I sat next to Matthew Drake for dinner, and we discussed this heavily. And yes, he, you know, in conversation, he'll acknowledge the fact that he'll use teriparatide in this population.
To be fair, your patient doesn't seem to have, I mean, we're not even sure she has an MGUS, right? I mean, she's got renal disease, and she's not clearing. She has a negative SPEP and a negative UPEP. So just for clarity, I mean, I think it's worth a discussion in patients who do have MGUS, but I don't think we have evidence that this patient has MGUS.
Standard doses of abaloparatide or Forteo?
Yep. That it?
So if you used a PTH analog, what would you follow it up with?
What's the question?
If you used a PTH analog in someone on dialysis, what would you follow it up with? Would you use a bisphosphonate or would you use DMAP or would you just not?
Yeah, I tend to use very low dose recidronate, 35 milligrams every other month, every other week, twice a month. And that's based on two observations. One is from Mike McClung's New England Journal paper on the HIP trial, where they had one group of 5,000 plus patients that were treated with placebo, 2.5 milligrams a day of Actonil, or 5 milligrams a day, and the hip fracture reduction was equal between the two doses. And then there's the data from the European arm of the vertebral fracture studies of Procter and Gamble on recidronate, showing the same thing, where they maintained the 2.5 milligram for 3 years in Europe, and they dropped it in the United States for political reasons. Bobo?
Paul, could we get back to the bone turnover marker? It's my understanding that the assay that uses a intact P1NP, the trimeric form, is still valid in renal failure. I don't know about in dialysis. Can you comment on?
I think it is.
Yeah,
As far as I know, P1NP is not clear about the kidney.
particularly the intact form,
Yeah.
the one that has the monomeric. There's another assay that picks up the,
That's the Roche.
Right.
It's not FDA approved yet.
Right.
Just a follow-up question for you, Dr. Miller, because I heard you talk about that protocol on echo a while back. In a patient in this kind of renal condition, would you still be able to do that with your Syndronate or no?
Yes, I think so.
Okay,
Mm.
thank you.
We have a question online about diabetes and how, that may cause bone weakness or, kind of bone architecture changes. I don't know if anyone wants to comment on that. Advanced glycolation products of diabetes, like leading to that.
I don't know that, so.
Not necessarily for you, but for anyone else. I don't know, maybe for Dr. Stein.
So in terms of the accumulation of the AGEs in bone, so they directly compromise the material properties of the bone. Like Eve Donnelly, who's up in Ithaca, has done some really nice work showing that that's how they directly affect the strength, but also, indirectly through lower bone formation also. So there's a lot of different ways that they're increasing fracture risk, but usually we don't see that the bone density in those patients is lower. There are some increases in terms of cortical porosity and some microarchitectural abnormalities that we see as well.
Interestingly, in multiple observational studies, the existence of DISH is diabetes is associated, type 2 diabetes, which was interesting to see. I don't know why.
All right. Do you feel like you have enough to go on to?
Thank you very much.
Thank you.
Yep. Our third case by Jillian Woodridge. Your title slide, Jillian.
Oh, yes. I always like to do kind of funny titles. Maybe they're not funny. I don't know. I think they're funny. But I always like to leave a little mystery, right? So hi, everybody. I'm Jillian Woldridge. I'm a primary care sports medicine physician down with Houston Methodist. I still do regular kind of jock doc sports med stuff, but then also do a substantial amount of osteoporosis and bone health. Oops. Oh, sorry. Do I do okay? Do I just hit okay?
Doing that session close thing again.
Subscribe, retry, or okay? Which one should I hit? Retry. So noted. Connecting. All right, let's see if that worked. Sweet. Okay. So for disclosures, it's not particularly relevant, but I always get worried that I'm going to somehow get in trouble with some sort of CME oversight. So I'm on the speaker bureau for Kyoa Karen. So for mine, this is going to be a little bit outside of maybe the traditional osteoporosis talk, but I still thought it was a very interesting case. I'm a team physician for a D1 university. And I had, back in 2021, I had a 20-year-old football player who came in to see me with he came in to see our specialist, hip specialist, with bilateral hip pain that was starting in August of 2021 during kind of practices and training camp. His pain progressed over the next month, and MRIs of the hips and femurs showed a pretty extensive bony edema. He had bilateral anterior femoral neck stress fractures, as well as stress reactions in the medial femoral shafts. And I did include, because his MRI was pretty impressive, I included it here. You can, the femoral necks are not particularly well visualized in this view. I apologize, but you can just really see the amount of edema, especially in the periosteum on both sides, left greater than right. His left side was more painful. You can see some of the cortical thickening. So I thought it was very, I don't know, that's what we look at in my little jock doc world. So he was sent to see me. After that, I do pretty much all of our stress fracture bone health assessment at the university. And so he was sent over to see me. It passed medical history, just seasonal allergies. He never had surgery. In his family history, he thought his mom may be developing osteoporosis, and there were some family members with stress fractures with running. For his social history, no tobacco, no alcohol, no illicit substances. He's a pretty straight-laced kid. He was not taking any medications or supplements at the time. He had no history of low trauma fractures. His dietary calcium intake was fairly high, so these guys are always just kind of struggling to take in enough calories, and so they tend to lean heavily on things like whole milk and a lot of protein shakes. So he was probably doing about 44 ounces of milk a day, was also getting a fair amount of cheese. And then they offer the Fairlife protein shakes in our athletic training room. I one time pulled up what was actually like in it. Well, not just Fairlife, we had some other ones too, but one of them had like 875 milligrams of calcium. So they can be pretty high calcium. So just keep that in mind going forward. His exam was fairly unremarkable. He's a pretty tall guy. He's about 6'6", 107 kilograms. He's one of our tight ends. This was his bone density. I do apologize that the numbers are a little bit small, but we obtained axial as well as peripheral DEXA, and his Z-scores, obviously we'll look at Z-scores, in the spine are all pretty high. You're looking at numbers of like positive, 3.9, positive 4.2. So overall his spine is about positive 3.8. His hips fall within normal ranges, as does his forearm. And you can see it's I think a fairly well quality done DEXA. His laboratory evaluation that was done, his visit with me showed normal testosterone, decent vitamin D, phosphorus was fine. You'll notice his PTH was low at 10. His CMP showed, pretty normal renal function. For the creatinine is hard to estimate in high level athletes because of their muscle mass. But he was normal calcemic, albumin was fine, alk-phos was fine. Celiac panel was negative. His 24-hour urine calcium was quite high at 670 milligrams. And my conclusion with this was, I think you are flooding your body with calcium, you're driving down your PTH, and you may be kind of shutting down your bone activity. So what I asked him to do was to try to cool it a little on the calcium intake. And I repeated his PTH about 2 months later. And while it was not normal, one could argue is perhaps trending in the right direction. And so we decided to leave it there. So again, our conclusion, decreased dietary calcium. He continued his partial weight bearing protocol per our hip specialist. He had follow-up MRIs in November of 21 showing improvement in edema. Then in January 2022, complete resolution. He returned to activity and training per our protocol, got through spring training in the spring of 2022, just fine, had no issues. Which brings us to August of 2022. So I don't know how much you guys know about football, but over the summer they're doing workouts, they're doing running and weights all summer long. And then starting in August, they actually do camp where they're putting on pads and helmets. And this is all regulated by NCAA rules. And basically after several weeks of this vague foot pain, he was stepping and felt a shift with significantly increased pain. This was his x-ray that was done. And if you'll notice right there, we have a third metatarsal fracture. What's kind of interesting is it has more of a pattern of like an acute fracture rather than the stress fracture that I would really expect to see. We don't really see a lot of periosteal edema or cortical reaction. So I thought it was kind of interesting that we didn't really get a lot of response in the cortex, considering he was having kind of vague pain for a while. So he comes back to see me. And at that time, he had decided to add in some fish oil to his life. He was on a multivitamin that had some vitamin D in it and just a little bit of calcium. His dairy intake was not decreased like I would have liked. He was doing about 32 to 48 ounces of chocolate milk every day. And about 12 ounces of whole milk and a protein shake and some cheese. And at that visit, he was like, oh, hey, my dad, by the way, has some kidney stones. So I repeated a lab evaluation, PTH still kind of low. He's normocalcemic, he's normophosphatemic, his vitamin D is fine, his total testosterone was more or less fine. And I was like, look, dude, you're still doing way too much calcium, please cool it. And then after about 2 weeks, on roughly about maybe 1,500 milligrams daily of calcium, he was still hypercalciuric. All right, so what did I do? Well, I decided to find someone smarter than me, and the person I know who's like the smartest in the world is Steve Petak, and so he graciously agreed to see this patient. And during that visit, again, he revealed to him that the father had a history of nephrolithiasis, mother had a history of metatarsal stress fractures with running, and the conclusion was still likely excessive calcium intake that was driving down parathyroid hormone, but given how high the bone density was at the spine, there was some concern about possible radiographic features of osteopetrosis. And so a recommendation was for spine x-rays and genetic testing. I just had him come into my office and we did his x-rays. So he has a lateral view of the lumbar spine that's there and a lateral view of the thoracic spine. You will notice that there is arguably a little bit of increased sclerosis at the end plates, but there are some orthopedic surgeons in here. So everyone who takes care of former like elite football players, whether it's NFL or college, probably knows that their spines are usually about 10 to 20 years older than they are, but certainly didn't have the really classic findings of the Ruger Jersey phenomenon that we would expect. Labs that were done at that visit showed a bone-specific alkaline phosphatase of about 23. PTH was actually 7 at the time he saw Dr. Petak, and a 125 hydroxyvitamin D was within normal ranges. Again, the x-rays don't demonstrate some Ruger Jersey phenomenon. And then he did undergo genetic testing for osteopetrosis type 2, and it was negative. Recommendation at that time was to decrease calcium intake to just about 800 to 1,000 milligrams daily and repeat labs. This time we were going to include bone turnover markers. So we communicated that to him. He met with our team dietitian to figure out a diet plan to do so. I apologize. That says December 2023. It was actually December 2022. So I'm keeping everything in chronological order. So December 2022, we ended up getting, and even at this point, he had barely started to decrease his calcium intake. His CT-low-peptide was quite high. P1NP was sort of at the upper range of normal. And so we thought, well, maybe it's just already gotten to the point where he's mobilizing his bone because he's gone through and he's just recently started to decrease his calcium intake. So we decided to follow it. So in February of 23, so just a couple of months later, his PTH was still low, his CT-low-peptide had gone up, and his P1NP had also increased. So again, maybe he's mobilizing bone, but why is that PTH not increasing? In March of 2023, early March, we got a repeat 24-hour urine calcium that was still very high at 672 milligrams. And we elected at that time to go ahead and get a renal ultrasound to look for any nephrocalcinosis. The read was not very strongly worded. It was possible increased echogenicity of the bilateral renal calyces, suggesting possible early stages, and he had normal cortices. Now, during this time, he decided to undergo a bit of a career change. So because he had now missed 2 football seasons due to stress fractures, and he was not planning on going pro or anything, this was football's way to get college paid for, he elects for a medical disqualification from football. And so I wrote that letter for him in January of 23. And it's because he plans for a career in the military. His dad was a Hyatt military guy, so he wants to go into the army, just like his dad. So that was great. And then he also decided to start marathon training because he wanted to stay in shape. And for those of you who may not know, the 2 probably largest cohorts of people that we study for stress fractures are military recruits and distance runners. So I was like, this is going to be fun, you know? Like, this will be great. So we decided then, as he's going into his fifth year, we got a follow-up bone density because we figured, okay, well, let's see what happens to his bones as he goes through and he decreases his calcium intake. These were done on the same machine. Everything was pretty equivalent. He has actually now had like a 4.6 decrease in bone density at the spine. He's had about a 5.2% decrease in bone density at the hips, and then his forearm is pretty stable. Now, I will say we do not have LSCs. So in our radiology department where these are done, we actually don't have like a least significant change. So, but those are like not numbers to sneeze at, right? So it's still maybe I would consider to be clinically significant loss in bone density. So we have more follow-up testing. So we got the bone density, but we also got some additional labs. CETO-peptide remains high, P1NP remains high. He's still normophosphatemic. His PTH is still low. His 24-hour urine calcium, if anything, has gone up. And we got a PTH-RP that was actually undetectable. So that's just great because it still doesn't make sense. And so in February of 24, repeated the labs. We're just thinking maybe it'll change because the definition of insanity is doing the same thing over and over and expecting different results. And still has low PTH, still normophosphatemic, bone-specific alkaline phosphatase is still fine. P1NP, CETO-peptide, arguably maybe a little lower than before, but still high. And his 24-hour urine calcium remains high. In March of 2024, we got a follow-up renal ultrasound showing that this time the radiologist was a different one reading it, said the renal calyces were kind of normal in echogenicity. They did not feel like it was increased. So this young man and I met, oh God, was it April? So I talked to him just a couple of months ago, and the question was, well, what do we do from here? But for some follow-up for you guys, for the record, he ran his first marathon in January of 2024, and he did awesome. Not quite as good as he wanted to do, but he did really well for his first time. And there have been no bone stress injuries whatsoever. So he's now been running for 18 months at this point, or over 18 months, and he's done fine, no stress injuries. So I have a couple of questions. So first of all, what is this? Is John Belzikian tuned in, by the way? Oh, rats. Okay. All right. So that would have been great. But that's okay because you guys are also amazing at this, but Bill Zekian would have been a little helpful. I may like get his email. Is he here? Virtually?
I see him
in spirit
online virtually.
Okay. Maybe he'll chime in at some point. So the question is, what is this, right? Because we couldn't find a entity that really kind of described this, even with having a limited calcium intake. And then the question is, how do we monitor going forward? So now he's going to be entering into the Army, and he'll have actually very excellent medical care. And so the question was, what do we do bone density and lab frequency wise? Do we continue to monitor this? Do we continue to look at his bone density? And then at what point do we actually consider pharmacologically addressing his hypercalciuria? Because to me, at least, it seems like he's probably mobilizing some bone. And so even though he's reaching more normal levels, I do get a little bit concerned that at some point we're going to start to actually compromise his bone health by basically, right, his body's going to be taking out some of his calcium from his skeleton to keep his blood level steady. So at what point do we look at addressing that? So those are my questions.
So first thing that comes to mind for me is that he's hypercalciuric. He has a high 125, a low PTH, and fractures, high bone turnover with a low PTH. So this would all be consistent with the 24-hydroxylase deficiency, which is one of the things that I presented. And I would recommend, rather than getting a single gene test, get a gene panel. And if it'll confirm or not confirm the 24-hydroxylase, but it'll also give you 399 other possible genetic conditions. He's got some, I think, underlying genetic condition. I don't think this is from taking too much calcium in. So that's what I would do. I would follow the 125. I get them tested for 24-hydroxylase deficiency. You could also look at the other vitamin D metabolites. They can be ordered, but I think genetic testing would be the simplest, quickest way to get to an answer.
For use 47 point outside your normal range.
Barbie?
The 40, I have the 125, excuse me.
So
is that outside your normal?
It's high for somebody who's hypercalcemic.
Okay.
And with a low PTH, I mean,
but
PTH is what.
He's normocalcemic.
So, but PTH is what drives 125 and his PTH is low. So he's got something driving his 125 formation. So.
Okay. Makes sense. Oh, no.
I mean, don't you think that those folks with the they usually kind of declare themselves as hypercalcemic at some point, right? Like under that kind of stress, that kind of calcium intake, like the infants who, I mean, that was how it was initially found, right? I mean, I'm impressed because I was wondering that too, but he's not.
I think we're just beginning to see the spectrum of this
Yeah.
disease. And I think that he's probably on the milder end of the spectrum. He's gone this long without getting noticed. He's been super healthy and strong. But I think, even if it's not that, and it's quite possibly not, I do think that he's got some underlying genetic condition. I would do a wide skeletal dysplasias, mineral metabolism, genetic testing.
And then tests for alpha hydroxylase as well. Is there a test that exists?
You can get measured 24-25 hydroxylase and 124-25 hydroxylase. There is a place that does that commercially. It's in the Midwest. What's it called? It's like Midland Laboratories or something like that. You could look up and see who measures the metabolites of vitamin D. Do they?
Yeah, they do the 24-25 ratio, right?
Yeah, that would be actually, I think that's the most sensitive is the 24-25 ratio.
Lynn Kohlmeyer, great case. What about his father's stones and his urine citric acid and oxalate, and what is his salt intake? And lastly, I know he's an athlete, so this isn't really getting to his bones, but what about a thiazide?
So for his dad, I remembered asking, I was like, hey, tell your dad before, because his dad was retiring. He was pretty high up in the Army. I was like, your dad's retiring. So on his exit physical, have them do a PTH and a 24-hour urine calcium, and they didn't do it. Because it would have been really nice to, see some kind of consistency. As far as you were asking about like salt, or I didn't do like a stone panel. Do you mean dad's, like a stone panel for dad? Yeah, they didn't do urine testing, which is unfortunate. Even for him, so I did not do urine citric acid testing or oxalate testing, but certainly something to consider. He doesn't have a personal history of stones. There were no stones seen on his ultrasound, but it's something to consider. Salt intake, I'm going to assume for a young guy in his 20s, is probably going to be pretty bad. And meaning it's going to be probably pretty high, especially because obviously they're consuming electrolyte beverages and all of that. They're working pretty hard. And then thiazide diuretics. So they're banned by the NCAA. All diuretics are because they can hide, because it dilutes the urine so much, it can hide any illicit substances on drug testing. So for an athlete like this, if anything, we would consider like Eurocit K, because it's not banned.
I would worry about his stone risk. And I think I would do, I don't know if you have access to the Litholink test, which is a helpful panel, because one thing that I was wondering about as you were presenting is what was his urine volume for those 24-hour collections. And that's, usually one of the first things we try to address with somebody who we think is at risk at stones is the volume. But what were they? Were they very high? Is that calcium, that you're getting in the 600s or even the 800s? Is that with an extremely high urine volume?
I was looking at, most of them were reported. He was probably anywhere between like 1,500 milliliters, close to 2,000 milliliters of urine in 24 hours.
So that might be something that you want to address with him. And then all of the things that were mentioned about the sodium, and because I think that he is at high risk for that. And I think also the 25D that you showed was a little bit on the higher end, wasn't it? Higher than 50?
Oh no, his 25.
Yeah.
It was like 38, like 36, 38.
Okay. Because we see a lot of patients who are taking very high doses of vitamin D, and that certainly affects their urinary calcium too.
Yeah. I had one patient, her level was like 222 because she was taking 50,000 units daily. That was great.
Chris? Yeah, Chris Morganti, orthopedics, now from Madison. This is separate from the things you're thinking about, just to sort of widen the spectrum. So obviously, if you find a genetic disease, great, because you have an explanation. But as far as his future, like he wants to not be limited by function if he wants to be in the military, the diagnosis there with the stress fractures that you noted on the medial side. So was a series of those. They're called thigh splints. There's a series of those out of Brown, and those were completely not related to any metabolic disease, but to playing surface.
Mhm.
And same thing with the stress fracture in the foot also could have been. And he sounds like he's a hard charging guy. So if you find a diagnosis, obviously treated, but if you don't find one to address his training regimen, because that could be, if not knowing all these labs, I would have definitely talked to him about playing surface, biomechanics, shoe wear, could explain all those orthopedic injuries that you saw on there.
Especially, it was very odd that he had anterior femoral neck stress fractures.
Yeah, I couldn't see that on the image, so
was-
I sort of was discounting that, but
It's
then.
on his,
Yeah.
it's on the MRI, because he had MRIs of his
Yeah.
hips first, and then when
Yeah.
they saw some edema in the
Yeah.
femoral shaft, then they got bilateral femurs.
Yeah.
Yeah, we have turf. We have the typical, turf with like the rubberized,
Yeah.
ground up tire that they're playing on, but they practice predominantly on a grass field. And then it was his stuff predated this. We did end up getting a bubble that also had a synthetic field on it. And then of course, he's in cleats during training camp when a lot of these happened. But most of their conditioning is done in like your typical running shoes. But yeah, no, the medial side was extremely unusual because
Yeah.
usually you expect like lateral.
Yeah, and it's interesting just because this came to my awareness because all of a sudden they're changing shoes and these super shoes, and I've had like an injury I never heard of in 20 years, and all of a sudden I had 8 of them, and it's all because of a change. So the series out of Brown was a change in surface, and the change in shoe was related to these. So it might be something to consider.
Yeah,
just for
excellent. Thank you so
counseling. Yep.
much.
One quick question online for the calcium gurus here. Will, they're debating about HCTZ, I know it may be off for him, but just in general, that if it reduces urine calcium, will it actually raise PTH in someone like this, or someone who does or doesn't have an underlying PTH abnormality? Like, would you expect the hydrochlorothiazide itself to affect PTH?
Well, if it lowers his urine calcium and raises his blood calcium, it would lower his PTH. Even more than it was, unless I'm trying to think, is there any calcium?
And it could go in
sensors out
both
there?
directions there, right? Because like the patients who it unmasks their hyperpara,
I
right? It
think it
raises
can-
their
Yeah,
PTH.
it
but-
can do that as well. Like sometimes we think of that as a reason for someone's slightly elevated PTH, and sometimes we'll stop it and then re-challenge it. So it can do that as well.
You want, Dr. Burstein?
Thank you, Dr. Miller. I would question whether his persistent hypercalciuria is possibly due to him. I mean, he's an athlete. He may not be restricting dietary calcium as much as we would like him to restrict. And one of my thoughts just before I came up was if he's using protein powder. I just looked up and there's significant amount of calcium in at least whey protein powder. So I just wonder if he's really restricting as
We-
much as we would like him to.
And you bring up an excellent point. So we went through that. What I love is this is probably like my one football player who I know is going to do exactly what we ask him to. So, and what's nice, he did meet with our team dietitian to go through and create a meal plan. I asked him to bring in or to take a picture of the back of his protein powder bottle. And so the one that he has actually does not, because it was not whey protein based. I think it was based on something else. That way it was low calcium. You bring up excellent points because I wanted to make sure I was like somehow calcium is sneaking in here. And so, and we kind of went through like, what are you doing? Breakfast, snack, lunch, dinner. And he's really taking, and he maybe does the occasional yogurt, but he's basically eliminated like dairy from his life, which is maybe a little bit miserable for him. But yeah, you bring up excellent points because I was like, it's got to be sneaking in there somewhere. And I just was not able to identify if he was getting any extra calcium.
Okay, thanks a lot.
Steve?
Yeah, I'm following several families with CYP 24A1s, and it's very unusual, the bone density being so high in this particular gentleman seems to go against that, and I think looking for that is reasonable, but I'm not hopeful that that'll be the answer, although it should be looked for. But the very high bone densities is kind of an unusual feature in that type of a setting, even though he may have had a football history. So find that to be curious.
I think of some of these difficult patients, you really have to look at the family. They've got to get the father in and see if this is running, and you may get better hints from the father than from the kid. What's wrong?
Any other questions? I think that's the time for thank you very much.
Thank you.